Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we're going to be talking about mild to moderate atopic dermatitis, the burden of disease, and topical pathway. Our moderator this evening is Dr. Leon Kircik, who's the president of the International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai, New York, Indiana University Medical Center in Indianapolis, and also medical director of physician skincare, DermResearch, and skin sciences. Our speaker this evening is Dr. Linda Stein-Gold, who is the director of clinical research at the Department of Dermatology, Henry Ford Health in Detroit, and division head dermatology, Henry Ford Health at West Bloomfield in Michigan, and past vice president of the American Academy of Dermatology. We would like to thank Incyte Dermatology for making this educational event possible. Before we begin, if you're having technical issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. Within 1 to 2 days of the webinar, a survey link will be emailed to you. We greatly appreciate it if you could fill it in and send it back to us. Again, if you want to submit your questions to our faculty, please submit your questions in the question chat pane on the right-hand side of the screen, and I wrote a note there so you can see exactly where you need to type in your questions. So without further ado, I will pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone. Welcome to another educational evening from International Dermatology Education Foundation. And tonight we do have a special guest again. There was a special demand from last night, and tonight we invited Dr. Linda Stein-Gold again, and she's gonna tell us. Next slide, please. She's gonna tell us all about a new treatment option. And before we go there, however, I want to tell you a little bit about International Dermatology Education Foundation. We are a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. Now, we have been around for a long time, but recently, since the pandemic, we are extending our educational programs virtually all over the world, not only North America, not only in US and Canada, but also in South America, as well as Southeast Asia and Europe. So tonight, again, as I mentioned, we have Dr. Linda Stein-Gold. By the way, please do follow us at Instagram, Facebook, as well as LinkedIn. Next slide, please. So Linda is going to tell us all about mild to moderate atopic dermatitis, burden of disease, and a new topical pathway. So welcome back, Linda, after a special demand. So please go ahead, take it away.
All right, Leon, thanks so much. And what a treat it is to be here with everybody. And thanks for joining me today. It's really an exciting time for atopic dermatitis, especially mild to moderate disease. And today I'm going to talk about the importance of topical JAK inhibitor for the treatment of mild to moderate atopic dermatitis, and why does it make sense to use a topical JAK inhibitor for this particular disease. I'd like to thank Incyte for sponsoring this presentation today. As you know, I'm speaking on their behalf, so we have to stay on label because this is a promotional program, but we have just a wealth of information to talk about today. So to start off, let's talk about the indications. Ruxolitinib cream, or Opzelura, is a 1.5% cream that's indicated for the short-term and non-continuous chronic treatment of mild to moderate atopic dermatitis. And we'll talk about what does that mean, short-term and non-continuous long-term. It's for patients who are not immunocompromised or at least age 12 and up, where their condition is not adequately controlled with other topical therapies or when those aren't advisable. It's also FDA approved for patients age 12 and up in non-segmental vitiligo. And it's not recommended to use Opzelura in combination with other biologics, JAK inhibitors, or potent immunosuppressants. Now, there is a boxed warning associated with ruxolitinib cream, and we'll call out serious infections leading to hospitalization or death. high rate of all-cause mortality, including sudden cardiovascular death, lymphoma and other malignancies, higher rate of MACE or major adverse cardiovascular events, including cardiovascular death or MIs or stroke, and thromboses, including DVTs, PEs, and arterial thromboses. And we'll talk more extensively about the safety information later in the presentation. So let's first start by taking a step back and talking about atopic dermatitis and really trying to understand this disease and the mechanism of action. This is one of the most common inflammatory skin diseases. We see it probably every day in practice. We might even have some family members ourselves who are affected by this. It affects about 13% of children and about 7% of adults. And we know that about 30 million Americans are affected, and we think that this number is going to potentially increase with time. And when we look at our entire bucket of atopic dermatitis patients, the vast majority actually have mild to moderate disease. Now, when we think about atopic dermatitis and we ask patients, what bothers you the most? It turns out that it's a combination of things. They're certainly upset about the rash, but they're almost more upset about the itching. So we have to, when we think about a therapeutic strategy, we have to really target that itching as well as the rash in order to holistically get these patients under control. So when we think about treatment considerations, we have to realize that patients can have different types of disease severities. Even within the same patient, you might see mild disease in one area of the body, moderate disease in another area. And also when we see you in clinic, we only see a snapshot in time. So we really need to take some time to ask the patients about their particular journey. We have to realize that patients can have disease on many different body surface areas, including sensitive areas, including the face, including around the eyes, including in the genital area. And we need to simplify the treatment regimen. I think about when I first started in practice, I thought, I'm going to be a great dermatologist. I'm going to give you something for flare-ups, something for maintenance, something for sensitive areas. And it wasn't unusual for me to write 4 prescriptions for a patient. And I realized once they get home, they're almost incapacitated by fear. They're so confused, they don't remember what to do with anything. And we all have those patients that come into our office, they're holding a bag of medications. They have no idea what's in there. They don't know if it's expired. Some of the tubes have never been opened. Simplify the treatment regimen. Let's set them up for success by potentially giving them one medication that can be kind of nonstop, like something you can use on multiple body surface areas. So simplify the regimen. And basically we need to get these patients under control and keep them under control. So let's talk about why ruxolitinib cream or Opzelura makes sense when we look at the pathophysiology of atopic dermatitis. When we think about atopic dermatitis, we understand that this is a complicated disease that involves multiple different facets. We know that there's an abnormal barrier. In atopic dermatitis, we have a decrease in tight junctions. We have a decrease in antimicrobial peptides. We have an increase in staph. We have a decrease in filaggrin in a number of patients. And all of this contributes to this leaky barrier. So we see an increase in transepidermal water loss, and we see an influx of allergens and antigens. And with that influx, we see an activation of the immune system. As that immune system is activated, especially the Th2 type immune response, we see that they release a number of pro-inflammatory cytokines, not just one, not just 2, but a number of these cytokines. And these include IL-4, IL-13, TSLP, IL-31. And these cytokines act by increasing that inflammatory influx into the skin. They act either directly or indirectly on the sensory neurons to increase and amplify the itch. And they also act directly on the skin barrier. And those pro-inflammatory cytokines themselves can have an effect on the barrier. IL-4 and IL-13 can downregulate filaggrin, and we see an increase in itch, an increase in scratching. And basically this whole cycle repeats itself. As we scratch, we inflame the barrier more, we have more inflammation underneath the skin, we further get a compromised barrier, and it's just a vicious cycle. Now, looking at some of the key players that are involved in atopic dermatitis, again, it's not just one It's not just 2, but there are several, and some of them include IL-4, IL-13, IL-31, and TSLP. And these cytokines play a role in triggering pruritus or itching, in IL-4 and promoting the Th2 cell differentiation. We see that they have a role in increasing inflammation and increasing activation of T cells. So it's not just one, but ideally we could target multiple cytokines in order to get this disease under control. Now, what is actually going on in the body? We talk about these cytokines, but what does that mean? These cytokines are floating around. How do they tell the cells to cause inflammation and produce more pro-inflammatory cytokines? Well, they do this by binding to receptors on the surface of the cell, and the cytokines are carrying an important message. This message is to create havoc and creates lots of inflammatory proteins. So they bind to the receptor with that message. That receptor is part of a JAK-STAT pathway. These 2 JAK enzymes come together or dimerize. They receive the signal. They get the signal. And then they are phosphorylated and they serve as a docking station for the STATs, or the signal transducers or activators of transcription. The STATs are kind of like the waitresses in the restaurant. They pick up the order. Okay, you want to make some pro-inflammatory cytokines, some more? No problem. I'm going to pick up the order and I'm going to go off to the kitchen or the nucleus, and I'm going to oversee the production of these pro-inflammatory cytokines. Now, if we want to stop this process from occurring, we could stop the conversation from occurring where we're communicating that inflammatory message. And one way to do that is to act on the JAK-STAT receptor. What ruxolitinib does is it inhibits both JAK1 and JAK2, and these are key cytokines that are involved, or key JAKs that are involved in the transmission of the inflammatory message from many of those key pro-inflammatory cytokines, including IL-4, IL-13, IL-31, and TSLP. So by blocking the JAK pathway, we block the message from being delivered. So that's in theory what's going on. Now, does it actually happen in practice? So we'll take a look at the results from the phase 3 clinical trials. We have 2 identical studies which looked at patients age 12 and up who had mild to moderate atopic dermatitis. We're going to look at efficacy, we're going to look at safety. So the first thing we want to understand is, how are these studies designed? And these are, again, are 2 identical studies that looked at patients 12 and up with mild to moderate disease. They had between 3 and 20% body surface area. They applied medication twice a day for 8 weeks, every day continuously for 8 weeks. So we might consider the 8 weeks to be a short-term treatment option. We used the Opzelura, which is the 1.5% cream, as well as a lower concentration, the 0.75% cream, as well as the vehicle. At the end of 8 weeks, something really unusual happened. We allowed these patients to go into a long-term study where everybody was treated with active drug. They either got Opzelura or they got the lower strength 0.75% ruxolitinib. This study was designed in a different way than what you're used to seeing. Patients treated their lesions until the lesion itself became clear. Then they treated for an additional 3 days to make sure that lesion stayed clear. Now, once any particular lesion became clear and was treated for an additional 3 days, you would stop treatment to that spot. But if you continued to have lesions elsewhere, you could continue to treat those lesions. If you got new lesions, you could start treating those lesions. So the patient was really in charge of their own destiny. They were allowed to stop and start their medication as instructed. They didn't have to stop when they got to almost clear, and they didn't have to restart when they got to mild. They could restart their treatment as soon as they needed to, as soon as the disease started to come back. Very much a real life scenario. So the primary endpoint is getting patients to clear or almost clear in terms of the investigator's global assessment. And that means looking at the entire body and saying, are you completely clear with no pink skin? Are you almost clear where you might have a little bit of residual pink, a little bit of thickness somewhere? And you have to have that 2-grade improvement. And the reason the 2-grade improvement is important in this particular study is because if you started with mild disease, you had to get to completely clear skin. So you couldn't be almost clear. You had to be completely clear. And then the secondary endpoints were looking at the itch over time and also looking at how many patients had a 75% improvement in their EASI score. So it's important to understand who came into the study. And 20% of the patients were adolescents and 9% were 65 and over. So we have a good distribution by age. We also have a very good distribution by race. 70% white, but 23% Black or African American, 4% Asian. 75% of the patients had moderate disease, 25% mild. And notice that the mean body surface area was about 10%. So they really have a good amount of disease at baseline. Their mean itch score or worst itch score at baseline was a 5 out of 10. It's also important to note that almost 40% of patients who came into the study had facial involvement, and their body surface area was between 3 and 20%. So just looking at these demographics, generally these patients, the majority of them would probably be receiving multiple prescriptions from their provider at baseline because they have a lot of different sites that are involved. Okay, 2 different studies. We're going to look at the proportion of patients who got to clear or almost clear with that 2-grade improvement. And as somebody who does clinical trials, the first thing I look at is, do we have good reproducibility of the data between the 2 trials? And the answer is yes. Great separation as early as week 2, which was the first time point, continued improvement over time with over half the patients getting to clear or almost clear using this drug as monotherapy over the course of 8 weeks, BID. Nice separation from the vehicle. Here's an example of a patient at baseline. You don't have to ask him if he's itchy. We can see the excoriations. He's a moderate at baseline. By 2 weeks, he became an almost clear, and by week 8, he continues to be an almost clear. This is an example of a patient in real life. 67-year-old Asian man with a lot of hand involvement. He's got moderate disease at baseline. And by week 2, he's already at an almost clear. Now here's another patient, a 33-year-old Black woman. She has moderate disease, and I think you can appreciate the thickness of the lesions, but also the hypopigmentation. And we see at week 6, she has a nice reduction of the thickness of the plaques, and also she's starting to have a normalization of her skin tone. So very nice results. Okay, what about reduction of itch? When we're looking at a 4-point reduction in the patient's worst itch, again, very good reproducible data. We see separation by week 2 with about 1/3 of patients having that 4-point reduction of itch. And at the end of 4 weeks, we see over half the patients had that 4-point reduction. And we actually saw a meaningful reduction in the 4-point reduction as early as day 2. Now that's a 4-point reduction. A higher bar is to ask how many patients got to clear a 0 or 1, meaning no itch at all or minimal itch. That's a really high bar, especially with these patients who have significant disease. Yet when we look over the first week, we see separation starts at day 1, and by day 7, 36% of patients have a 0 or a 1 for their very worst itch. So that's a nice improvement over time. Now, this is an interesting study that was done in adults, 46 adults, in an open label study where everybody got medication. And the question was, how fast does this drug actually kick in? So I'm going to bring you into my office. I'm going to treat you with active medication, and I'm going to evaluate your itch at 15 minutes after application, at an hour, 2 hours, 4 hours, 6 hours, and then 12 hours. And what was found was, as early as 15 minutes, there was a noticeable reduction of itch. At 15 minutes, their worst itch score went down by 2.3, and they had that 4-point reduction by hour 4. So we can see that this is something that actually kicks in quite quickly, at least in this open label study. A secondary assessment that was done was the EASI 75 or a 75% reduction from their baseline EASI score. And we see again, really good reproducible data, up to 36% of patients having an EASI 75 at week 2 and over 60% at week 8. So really nice results and very good reproducible results over time. Okay, let's talk a little bit about safety. This is a topical JAK inhibitor. What adverse events were seen more commonly on active drug as compared to vehicle? And we see the percent of patients having any treatment emergent adverse events a little bit higher in the vehicle group versus the Opzelura group. We see nasopharyngitis a little bit higher in the Opzelura group. And then as listed, as you look down, you can see the incidence, which was one patient in the group, or I'm sorry, 1% in the group of the other adverse events as listed here. There was a low rate of application site reactions like burning, which occurred in less than 1% on Opzelura versus 4.4% with vehicle. Itching, nobody on Opzelura versus 2.4% on vehicle. And a really interesting number is the patients who discontinued due to adverse events. We found less than 1% on Opzelura versus 3.2% on vehicle when we look at the two studies. As I mentioned, this was a long-term study that also occurred after the phase 3 trial. And one of the things we looked at was how many patients were able to maintain control when they used the topical ruxolitinib cream as needed. And what we found was that around 70 or more than 70% of patients maintained that clear or almost clear skin when they had access to the medication and used it on and off as needed. What about the body surface area? Remember, we started the study with a mean body surface area of about 10%. We saw a fairly rapid reduction on patients on active drug as compared to the vehicle. And even when the patients were transitioned over to vehicle, we see overall, we started to see that we went from a 10% to less than a 2% body surface area of involvement in the long-term extension. Now, I mentioned that patients could go on and off treatment as needed. They were allowed to stop treating lesions at 3 days after it became clear, but they could continue to treat other lesions. But if we take a step back and say, on average, how many days or months out of the year were patients able to go without any treatment at all? And it turns out that patients were off treatment for about 4.5 months during the course of the year. So that means that many patients had a bit of a drug-free holiday when we look over the span of the long-term study from weeks 8 to 52. Now, the 52-week long-term study is really a safety study. We're really looking to see if there are any new adverse reactions that were not picked up in the phase 3 shorter term study that lasted only 8 weeks. And basically what we found was that there were no new safety signals that were identified in the long-term study. And again, I want to reinforce that Opzelura is to be used for short-term and non-continuous long-term treatment of mild to moderate atopic dermatitis. Now, this is an interesting study that was done. This is a retrospective cohort claims data study. So this is an observational study that looked at patients who had atopic dermatitis, who are at least age 12 or up, who had a prescription for Opzelura. And what they wanted to do was look at the data for 6 months before the prescription was written and 6 months after the prescription was written, and try to see if there's a change in the prescribing needs of that patient after they received their Opzelura prescription. Now, in order to do this, they started with almost 4,000 patients, and they had to weed through the data and make sure that these patients were at least age 12, make sure that they had 6 months before and 6 months after the prescription was given, make sure they had a diagnosis of atopic dermatitis, make sure they weren't getting the medication for vitiligo. And the final sample size, when they tried to weed it all down and make sure it was a clean sample, was 1,581 patients. And the question is there something that happens after they get a prescription for Opzelura that really changes the nature of the prescribing habits? And what we found was, when we look at the prescribing habits 6 months before and 6 months after receiving Opzelura, the prescriptions for topical corticosteroids were decreased by almost 42%. The prescriptions for topical calcineurin inhibitors were decreased by about half, and the prescriptions for topical PDE4 inhibitors were also decreased by almost half. The other thing that's interesting is when we look at the biologic naive patients who are biologic naive before Opzelura, and when we look what happened 6 months after they got that prescription, we see that 92.3% of the patients were still biologic naive. Can't draw a lot of conclusions from this, but I think the data is quite interesting, that it does appear that patients are relying more heavily on the topical ruxolitinib than they are on the topical steroids, and perhaps they're under control better, such that they don't see the disease progressing to the point where they need a biologic drug. It's just some basic information, but it's interesting to look at. Now we'll take a look at a phase 2 study. And one of the big questions we have when we look at any non-steroidal drug is, how does this drug compare to the medications that I understand? And I understand topical steroids. I understand a mid-potency topical steroid like triamcinolone cream. Well, good news. When we look at the phase 2 studies that were done, these were dose-ranging studies for topical ruxolitinib cream, where different concentrations of the drug were evaluated and different dosings, including once a day or twice a day, were evaluated. And so they compared the different dosing schedules. They compared this to vehicle, but they also used an active control. And in this clinical trial, the active control was triamcinolone cream. The triamcinolone being a mid-potency steroid, they were only comfortable using this for 4 weeks. So the patients were treated for 4 weeks, then transitioned over to vehicle for 4 weeks. But this gives us some very important head-to-head direct comparison of Opzelura as compared with triamcinolone cream. And the phase 2 study had adult patients who had mild to moderate disease, again, 3 to 20% body surface area. And what we can gather from this phase 2 study, when we looked at a direct comparison of Opzelura versus triamcinolone, is we see that the improvement, the 4-point improvement in itch, was almost double with Opzelura versus triamcinolone. The treatment success was 38% for Opzelura versus 25.5% with the triamcinolone. The EASI-75, again, 56% with the Opzelura versus 47% with the triamcinolone, and that very high bar of an EASI-90, again, almost double with the Opzelura versus the triamcinolone. So based on this data, you can see in a head-to-head study, numerically, the Opzelura outperformed triamcinolone cream for each of these parameters that were assessed. I want to talk a minute about the box label, and a lot of you have probably heard where this comes from, but I just want to review it again. And there was a post-marketing safety study that was requested by the FDA to investigate tofacitinib. And the question was, how safe is tofacitinib? It's being studied, or it's being used in a rheumatoid arthritis population. The question was, is tofacitinib have the same safety profile as TNF inhibitors? Or is tofacitinib non-inferior to TNF inhibitors in patients who have rheumatoid arthritis, who are at least age 50, who have at least one cardiovascular risk factor? And each of these patients was using concomitant methotrexate. So it's a different type of a population. Again, rheumatoid arthritis population, over the age of 50, one cardiovascular risk factor. And what they found with this post-marketing study was that tofacitinib was not similar. In fact, it did have a worse safety profile than the TNF inhibitors. And the surveillance study observed an elevated risk of death, malignancies, excluding non-melanoma skin cancers, major adverse cardiovascular events, and venous thrombotic events. So in this study, they found an increased risk. So the FDA concluded that some JAK inhibitors for the treatment of inflammatory skin conditions may have similar risks. So out of an abundance of caution, they applied the same box warning to all JAK inhibitors, both oral and topical, that are being used for the treatment of inflammatory skin conditions. So that's why when we look at the label for ruxolitinib or Opzelura, when we read the label of the box warnings, it will refer to this particular study. So looking at the important safety information, when we talk about serious infections, it states that patients treated with oral JAK inhibitors for inflammatory conditions are at increased risk for serious infections that may lead to hospitalization or death, including TB, fungal infections, bacterial, viral infections, and other opportunistic infections. We want to avoid Opzelura in patients who have serious infections, and if the patient develops an infection and isn't getting better, consider stopping the medication. When we look at the adverse events of special interest, especially those adverse events that are called out in the box warning, and look at the exposure adjusted incidence rate of Opzelura as compared to vehicle, those are listed here. Now we do the exposure adjusted incidence rates and we call out the number of patients per 100 patient years. And the reason we do that is because by normalizing it this way, we can compare adverse event rates in drugs or vehicles that are being used at different time frames. So remember, the vehicle was only used for 8 weeks, whereas the Opzelura was used for 52 weeks. So we have to normalize it and say these are the events that occurred per 100 patient years, and they're listed here. Serious infections, 0.2 for Opzelura versus 0. Zoster, 1.1 versus 0. We see non-melanoma skin cancer, 0.4. Other malignancies, a bit higher in the vehicle group, 2.9. Cerebral vascular events, 0.2. And then pulmonary embolism and DVT, 0.2 each. So these are the numbers as we look in comparing to the vehicle itself. Looking further at the important safety information, the mortality. Here they're calling out that study that we talked about in the rheumatoid arthritis, where they saw a higher rate of all-cause mortality in that particular study. But they still say that we need to be cautious, consider the risks and benefits in a patient receiving Opzelura. Malignancies have been reported with Opzelura. Lymphoma and other malignancies were reported in patients receiving JAK inhibitors to treat inflammatory conditions. Now we're calling out that other study again, saying that there's increased risk, and we know the patients who are at highest risk are current or past smokers. Major adverse cardiovascular events, we're going to call out that other study once again. And again, note that patients who are current or past smokers are at increased risk for MACE events. Thromboses have occurred in patients in trials for Opzelura. And again, they're going to make the statement that we've seen this in that other study as well. If somebody were to develop a thrombosis, you certainly want to discontinue and treat appropriately. Okay, so what did we have? What do we understand? This is the first and only topical JAK inhibitor that we use twice daily. We can use it on up to 20% body surface area. We don't want to use more than 60 grams per week. We use it for mild to moderate atopic dermatitis. Treat it in the studies, the long-term studies, we treated it until clear. If you're not seeing the patients improve after 8 weeks, you want to reconfirm that they have the appropriate diagnosis and reevaluate. Don't use it in the eyes, mouth, or in the vagina. And it's a non-greasy, steroid-free cream. So again, more important safety information: thrombocytopenia, anemia, and neutropenia. These were reported in the clinical trials, but there is nothing in the PI that is essential to draw any baseline laboratory tests. Treatment with oral ruxolitinib has been associated with increased lipid parameters, but that was with the oral. Adverse reactions we went over in depth, but they're also listed here. Also for non-segmental vitiligo, incidence of in greater than 1%, or acne in 6%, pruritus, nasopharyngitis, headaches, UTI, application site erythema, and fever. This drug has not been studied appropriately in women who are pregnant or breastfeeding. And Incyte has spent a lot of time trying to make sure that our patients have access to the medications that we think are necessary for them. At this point, more than 80% of commercial lives are covered. You should anticipate having to do a prior authorization, and you want to make sure you have the appropriate information listed. Make sure the patient is at least age 12 with mild to moderate atopic dermatitis. Discuss the medications that they've already used, potentially a topical steroid or topical calcineurin inhibitor, and that you're treating only up to 20% body surface area. There's a copay savings card in place, and also Opzelura on track. I would suggest speaking with your rep to try to get all of the important details. So this is the first and only topical JAK inhibitor, FDA approved for mild to moderate atopic dermatitis in age 12 and up. It doesn't hit one cytokine, it doesn't hit two cytokines, but it hits multiple cytokines that are central to the pathogenesis of atopic dermatitis. We saw in the clinical trials that we have rapid reduction of itch and reduction of inflammation. In terms of adverse reactions, we saw them listed. In terms of tolerability, we see that this is a non-steroidal option that is actually very well tolerated. It's a non-steroidal injection-free, and I call this one-stop shopping because you can use it on the face, you can use it on the body. And if you want to take a step back and say, well, where would I prescribe this? What kind of a patient? Well, maybe somebody who has a really lot of itching. Maybe their itching is out of proportion to the rash that they have. A patient who has atopic dermatitis in multiple areas, the face, the hands, the arms, maybe in sensitive areas, where now you can write one prescription that they can use on multiple areas. Somebody who's had persistent atopic dermatitis, maybe it's not getting under control. Somebody, you know, when we studied it up to 20%, there are patients with that 10 to 20% body surface area. We could go topical, we could go systemic. Maybe somebody has 12% body surface area and they don't want to go straight to a systemic. Maybe they want to try a topical, and we have data to suggest that this would be perfectly appropriate for that patient. And adolescents, we have the FDA approval all the way down to age 12. So that's the good news, that we have something for the adolescents. So that concludes my overview. I think it's a really exciting time. We have an option that is a non-steroidal option. And for the first time with this new generation of non-steroidals, we can use a medication that doesn't cause stinging and burning, and we can use it on multiple body sites. So Leon, that concludes the formal presentation. Any questions?
So we do have a bunch of questions. We have over-enthusiastic audience here. One is, though, before I ask any question, you said that you thought you would be a great dermatologist by giving 4 prescriptions. I think you were still a great dermatologist, but now you are greater because you're giving 1.
Thank you. I agree. It's you know, it's hard because you think you're so good, and then if you're a patient and you receive all that, you're kind of like, well, what did he say? Does anyone remember what he said? I don't remember it.
Yeah.
And so keep it simple.
It happens all the time. So do you find, you know, you did the study, I did the study, I had almost 40 people in the study. Do you find what you saw in the study, the results, do they actually mirror in clinical practice?
You know, Leon, that's such an interesting question because, you know, we both do studies and we see a drug in clinical trials, and then we see the formal data that comes out from everybody's clinical trial experience. And sometimes we get all excited with good results, and then you get it in your hands, and I'm a medical dermatologist, as are you, and you use it and you're saying, well, wait, I don't see the same thing here that they're telling me they saw in the clinical trials. But in this case, I do. I really do. I see rapid onset of action. I see that patients are actually clearing with this as monotherapy, and I don't necessarily have to use a steroid.
So you did a really great job going over the adverse events, and one adverse event that sort of attracted attention, like the lipid abnormalities in the oral ruxolitinib, right? So do we have the same package insert and the same warnings with oral ruxolitinib?
Leon, that is just so interesting because we talk about these oral JAK inhibitors and topical JAK inhibitors for inflammatory dermatoses. But you're right, that's a misconnect, isn't it? Because the oral ruxolitinib does not have a box warning and the topical does, because the oral is not for the treatment of inflammatory diseases.
That's really good to clarify. The other thing is, and for those of us who don't do clinical studies, when you look at the adverse event, the way it's presented, it's per 100 patient years. And I always think about this, and the number for DVT, I believe, or PE was 0.2, right, on the active column. Does that mean that in order to get 2 DVT, I have to have 1,000 patients on this drug?
Yes. And you know, one of the things that we're not looking at here, and we've done with some other drugs, is looking at what is the incidence in the general community, and more importantly, what is the incidence in somebody who has inflammatory skin disease like atopic dermatitis. I think that helps to keep it in perspective, but we do have the vehicle versus the active. But I was reassured by seeing that these numbers look quite low.
Yeah. So, you know, I always think about it. In order maybe to get those 2, you have to have 1,000 patients on it. That means if I work every day, 365 days a year, right? Every holiday, every Christmas, every Rosh Hashanah, every, you name it, right? I still cannot get to that number. If I write 3 a day, I cannot get to that number. It's almost impossible. Anyway, the other thing I like the way you explained is the mechanism of action, right? I'm the customer, I went to restaurant, and if I kill all the waiters, I'm not gonna get any food. That's the bottom line.
You're gonna be hungry, yes.
Not because nobody is gonna be able to go to the kitchen and give my order.
Right, exactly.
So that's how the JAK-STAT pathways work.
Right. We have to transmit the message. You know, it's kind of like the cytokine is the person who comes to the restaurant, they place the order, the stats pick up the order, they take it to the kitchen, and that's how we make all those inflammatory proteins. If there's a block there, or the waitress takes your order but goes to lunch, and she never or goes home, she never brings the order to the kitchen, and you just don't get it. So
you know, conceptually, we are so used to how the extracellular molecules work, right? All the direct targeting cytokine inhibitors, how they work. So it's a little bit difficult for us to comprehend how the intracellular small molecules work. And this is a good way of, I think, explaining it. Now, the other thing is we are always concerned about the steroids and where I can use it, right? And the people get breakouts on their face, intertriginous areas, all these sensitive areas. Is it okay to use Opzelura?
yes, and that's one of the really beautiful things about having this non-steroid. You know, we've had non-steroids in the past where we could use them on the face and the sensitive areas, but a lot of them would burn. And so if you take a traditional non-steroidal and put it around your eyelids, you know, you might have to put some ice on it or something because you have a lot of stinging and burning. And this is fine to use in those sensitive areas because not everybody tolerated it perfectly, but the very vast majority of people did not have stinging and burning. So that was the good news.
How about duration, right? In the old days, we always worried about high potency steroids. I used to write on my prescription, don't use it more than 2 weeks, blah, blah, blah. What's the deal with that?
You know, Leon, it's so confusing because if you read the label, it says short-term, non-continuous, chronic, and you're like, what is that? So I take it by the clinical trial. The short-term to me is 8 weeks, and if you don't have an improvement in 8 weeks, you should probably reconsider your diagnosis. But remember, in the clinical trials, they treated the individual lesions. So there were people who were on medication the entire time. They just didn't treat every lesion the entire time. They'd treat till clear, then they'd go away from that one, then treat this one till clear. So looking at the studies, they just don't want you using it indefinitely. No, use your judgment. If after 8 weeks they're not getting better, reevaluate. If they're clear, stop using it. Go ahead and restart it as needed. And then once they're clear again, I like to give them that 3 extra days and then stop again.
And we do have data from the open label extension, right? People were on it, what, 48 weeks or so. And it was like a real life study, but people who didn't need it, they didn't use it, but some people did use it.
Exactly. And we don't, you know, the real reason we're doing it for long term is to look for side effects. And the good news is we didn't have any new safety signals that occurred. So that's reassuring.
So on that note, I think that was very eye-opening. Thank you very much, Linda. I really appreciate it. And I'd like to thank Incyte for providing this educational event tonight. Since we are done with the Incyte event, let's look at our next IDEF webinar. Roxanne?
Well, our next IDF webinar is this Thursday, and it will be thanks to the supporter Bayersdorf.
Thank you so much, and please join us on Thursday at 7 p.m. Have a good evening, everyone.
Thank you. Bye, everybody.